feedback from other surgeons. This is a most interesting thing for us to learn, to see
Absolutely.
that sometimes our actions could be different and we could deal with the situation better than we did.
Absolutely.
And Dr. Nato, one more observation is we show a case where things get complicated and we come out victorious. We do something really out of the box and come out victorious. But many times where things really go wrong, we may not really share the bad outcome. We normally show the good outcome from a complication. That is one way. No, we are not really be very transparent most times. That is probably a surgeon's ego, as you said, coming in the way.
Okay, so we are live now, but we'll wait for another 5 minutes because we have given time of 7 p.m. to start. Till that time, we can continue the discussion. And
I was just expecting all the judges to kind of share 1 minute of what what has been their experience of complications and how they have learned from their complications, or what exactly they feel. See, because my guru, my mentor, Dr. Pradeep Sharma, once asked me, he said, Dr. KP, why do you feel bad when you have a complication? Sir, I said, sir, the patient would have got good vision. Because of my complication, he's going to see less or not going to see at all. He said, that's not true. Probably you have hurt your own ego, no? That you have self-created ego that I'm a very good surgeon. And that ego which has been hurt is troubling you, not the so-called the magnanimity of yours. I think probably if you believe in the theory of karma, no, what you say, it's how everything in this world is predestined. Whatever that has to happen would have happened. So basically, once you have a complication, you should start thinking how to avoid it next time. Probably that is the only thing. It's like writing an exam and not worrying about what marks you get after the exam. You only have to prepare for the next exam.
Yeah. Professor German, can you please share your views?
Yes, I'm delighted to be with very experienced phacosurgeons, but I perceive the complications when I have it. It is the first step to improve myself. I'm a ophthalmologist. When I have cataract, I would like to go to somebody who presents his complications, because I believe that we are students in life. These cases, sometimes from junior guys, I think we are learning from it. I'm learning every day from each case I see. So the first thing is to be honest, is that to show the complications in a way that, not every day, in a way that you will get the experience of others and you will be better in managing these cases. Do you hear me?
Yeah, very much audible, very much audible.
We learn. I really learn from the most junior and I learn from the most senior. For example, when I see the chopper of Dr. Neetu, which is very long, and then I see the chopper of Dr. Mahanta, which is very tiny, it is really it is different experience. So we are learning. Never think that you are the best.
Absolutely. Dr. Pradeep, sir.
Hi.
So do you really have complications?
We must appreciate Dr. Pradeep sir, because he really shows the complications we face and we try to hide, and he shows how the way he manages. I think that's really appreciable. That's why we learn a lot from his videos.
I think in complications, first thing is accepting the complication. Like we all do complication. That is the first thing. Whenever juniors come and tell me this complication I had, patient moved the eye. Then I said, first you introspect yourself. Don't blame on patient. First thing is you accept it. That's the only way to improve upon yourself. So second is analyze. Once you accept the complication, second you analyze how could I have done better in this case. And best thing is to record your videos and see our own complications and be genuine to yourself at least. And how could I have managed this case differently? How could I have managed or avoided complication. Only thing is you should not repeat the same complication in similar situation. That is improvement. So that should be our aim.
Network bandwidth is low.
Exactly. So that's what I tell my postgraduates. If you do not know an answer for a very simple question, I can give you 24 hours time only. Next day, that same thing. I mean, you should have known by the next day.
Only thing is if
it happened once, not for the second day.
No, that's why whenever a PG comes, used to tell me, and I had this complication. I used to tell, you worry if you make a complication which is not written in book. If you come out with the complication which is already mentioned, you are not the first person to do it. Already somebody has done it. Don't worry. Don't repeat it.
Okay, I think it's 7 o'clock and the party attendees are joining, and I think it's time to start the proceedings. And I think now we have already formally welcomed all of you, and we are really grateful for your presence, all the judges as well as the chief guest and all the participants in this video competition. And as the first part of the agenda is there, Dr. Deepak Megur will be formally introducing our judges who have judged the videos for the webinar and also are there to help us during the webinar and give us some teaching tips during the webinar. So over to you, Deepak, so you can start sharing your slides.
Am I visible there? My screen is visible?
Yes, perfect.
Okay. So I'll be beginning with the introduction of our chief guest today, Dr. Krishna Prasad. We all know that he is a very passionate teacher. He heads the Department of Glaucoma, Pediatric Ophthalmology, and Refractive and Cataract Surgery in the MM Joshi Hospital, Hubli, Karnataka, India. I would like to call him, he's one of the last dying breeds. You know, he's the representative of one of the last dying breeds, that is a pan-ophthalmic surgeon. From the lids and orbit to squint, pediatric ophthalmology, to refractive surgery and cataract, he does it all. The only thing which he has not touched, hopefully, is the retina. So he is an exceptional surgeon, a very passionate teacher. He's a very loud teacher by among most of the PGs in India, and his passion to teach the postgraduates is really infectious and commendable. And he has been a personal mentor and friend to me and to many surgeons of our time. And we are very fortunate to have him here because we thought he's the right person. Because he's so passionate about teaching, we thought he's the right person to inaugurate our website. Our website's whole aim is to learn and to teach. And so Dr. Krishna Prasad, we are very we are very grateful to you for joining us, taking your time out and joining this program and agreeing to inaugurate our website.
Thank you, Deepak.
Yeah.
My pleasure.
Yeah. Next, we have, again, we are fortunate to have Dr. Nito Rosatelli from Brazil. And he has been in practice since for the last more than 20 years now. And he's a cataract surgeon who is employed with the Brazilian public health system since 1999. But I'm sure most of you are well versed with his super skills, which he has. Almost like, he's a magician, the phacosurgeon. His absolute mastery over the skills which he professes, and the speed and efficiency of his surgery is unbelievable. People who have not yet seen his YouTube videos, please do go and watch it. And he has got many unique surgical techniques which very few surgeons could dare to perform it. And it's our privilege to have you, Dr. Nito, here for this webinar. And I'm sure all the participants and all the viewers who are watching this will be greatly benefited by your deliberations. So thank you so much for joining. Next we are very fortunate to have another international faculty, Dr. German Al-Khatani from Saudi. He is an assistant professor of anti-segment and ophthalmic pathology in the Abdul Rahman bin Faisal University, Daman, Saudi. He's also the consultant ophthalmologist of King Fahd Hospital of University of Al Khobar. I hope I pronounce it rightly. He has done his fellowship from Walter Reed Medical Army, Washington, USA. Again, the common thread which binds us all is he's a very committed teacher who wants to share his experience with all the younger ophthalmologists and a surgeon par excellence. So thank you so much, Dr. German, for taking your time out and making yourself available for this webinar. We're grateful to you.
Thanks, Deepak.
Next, we have Dr. Ravindranath HM, and he's done his post-graduation from MD Ames, gold medalist. But most importantly, he's a man with the golden smile and also a man with a golden heart. I think that describes him. Apart from being an excellent phaco-refractive surgeon, he also specializes in squint, glaucoma, and neuro-ophthalmology. And most important thing, he is his loves sharing his experience. His humility is unmatched, and he has been a friend and mentor to me and many of my contemporaries alike. And I know him for the last 20 years. So, Dr. Ravindranath, I'm extremely grateful for being part of this webinar and sharing your experience. And I'm sure all of us are going to benefit from it. Thank you so much. And lastly, but not the least, we are extremely happy that Dr. Pradeep Mohanta could make it to this webinar, and he doesn't know any introduction because he has been the internet guru for majority of the budding eye surgeons worldwide. He probably has the largest number of surgical videos on YouTube, and his passion for teaching surgery is palpable if you just go and watch one of its video. And the amount of contribution which he has made in spending his time to motivate and teach surgical skills to the surgeons world over by creating various groups is unparalleled. Apart from being a highly skilled phaco surgeon himself, what is special about him is his humility. And of course, if you've not checked his YouTube channel, please do check it out. He's probably one of the most successful YouTuber among ophthalmic surgeons. I think that's it, Sourabh. Back to you. Sourabh, you're not audible.
Sorry, yeah. So thank you so much, Deepak. And now the next in the agenda is inauguration of the website, phacotraining.org.in. And I would like to request Dr. KP sir to inaugurate this website. So this is a kind of initiative, that we conceptualize together with me and Dr. Deepak, and why not provide a kind of platform for all of us, to contribute, and where there will be a categorization of videos and other things, and these webinars kind of thing where everyone can contribute. So this will be a kind of virtual inauguration. So maybe Dr. KP sir has that Harry Potter's wand to open the website. So I will just share a small video, and then with the flick of wrist, Dr. KP sir will inaugurate the video, our website. So give me just one moment. Okay, just let me know if the audio is good or
not. Audio is not coming. Audio is not there.
So let me just reshare.
visible.
Let me-
Only sound is coming.
Okay. So let me do it again. This is a common problem.
Is this the same file or different file?
It's the same file, but somehow, okay, I will do it directly. Yeah. Yeah, I think now. Okay, so if Dr. KP sir would like to give some good message to us, and then I will start the inauguration part further.
He has to say, I inaugurate.
Okay, over to you, KP sir.
Till I say that. Okay. So welcome all. I think this is a moment to cherish, and I personally, this is a very heartwarming situation for me. Both Dr. Sourabh and Dr. Deepak have been very close to my heart. We are very good friends. They consider me as one of their mentors, but not really. It is both mutual. I think we have come together on multiple occasions in the past. We have shared, exchanged a lot of good things about cataract surgery and phaco in particular. And this platform, phacotraining.org.in, probably is going to be the blockbuster because this is the need of the hour. We have so many of our contemporaries who we need to exchange ideas. So many of youngsters are looking up to us for ideas, postgraduates, residents, and this is a global platform. I think this is an excellent opportunity, and I am really take pleasure and great pride in inaugurating virtually, officially, the phacotraining.org. All the best to you guys.
Thank you, sir. Thank you so much. That's the flick of the wand.
Welcome to our website phacotraining.org.in. This is an exciting website that we have started, and the concept of the website is to train your surgical mind. So it has various videos, recent activities. You can see a lot of videos from us moderators, as well as there are lots of guest videos which include a lot of teaching stuff. You can also go to the videos list. There is a complete list of videos. You can see that they are all categorized, so you can go to the category that you want to see the videos from, and there are videos which have audio commentary and thinking process of the surgeon in different steps of the surgeries. There will be simple surgeries as well as complex ones. You will have lots of such teaching videos at one place. Not just this, but you can also submit your own videos for the website. This is a platform for all of us where you can share your ideas, you can share your complications and management of difficult cases. If you have any personal doubts about particular surgeries or surgical techniques, you can contact us anytime, and we are here to help you all. The good videos from the submissions will be also featuring on the videos of the month. We'll be also having regular webinars and also video competition. So stay tuned and also contribute to this platform, which is for all of us to learn together. Thank you so much, and welcome to our website phacotraining.org.in. Thank you.
So thank you so much, everyone, for being there for this inauguration ceremony, and we kind of find myself very fortunate to have this stalwarts. So without wasting more time, we'll start with our first video of the competition, and that is by Dr. Ravi Kulkarni. And I have already shared how it will be streamed, that we have already edited the videos, and so that we have the precise moments that we want to show. So and then the one of the judges. So for the first video by Dr. Ravi, Dr. Nito will be seeing and then asking the surgeon, Dr. Ravi, a question, and then there will be discussion to be followed. So here is the first video. To you, Dr. Nito.
Okay, hello.
Hello, sir.
Well, my question to Dr. Kulkarni would be, what do you think that was the main error or event that led to the PC rant?
Namaste, sir. Hello, good evening. I thought the last piece, when I was doing emulsification of the last piece, just before the last piece, the sharp end of the posterior side hit the posterior capsule. That was the reason for PC rent at the end.
Well, I chose this question because I think as we can see all videos of complications as learning tools. And so I decided to ask this specific question because if it was an error, that's the thing to be avoided. And well, in my opinion, it started when the nucleus fracturing was incomplete. I think that was the main thing that led to the chain of events and difficulty of getting the pieces separated and emulsified and easily emulsified that led to the complication. That was the, I think, in my opinion, ultimately, it was exactly what you said. The piece that you were emulsifying had some sharp edge and ended up provoking or causing a capsular rant. But I think this is a most important thing in hard nuclei is to completely fracture the nucleus before I start emulsifying it. That's because often it leads to some difficulty in dealing and manipulating these nucleus pieces, and we can cause a posterior capsular rant or a anterior radial tear, which is another complications frequently caused by this issue.
Thank you, sir. Thank you.
Perfect. Dr. Deepak?
Yeah, I just wanted to have one comment here. Dr. Ravi, you use AC maintainer actually, and it's a wonderful tool, but I would have used it before doing vitrectomy. Okay, you use it after doing a vitrectomy. The reason is when the eye becomes soft, it becomes quite difficult to thread in the your AC maintainer. And if you just put it before doing vitrectomy, as soon as you realize the PC rent is there, because you're so well versed with using an EC maintainer, just stick in the EC maintainer. Using that only, you perform all the maneuvers, including vitrectomy. Once the eye is soft, it's extremely difficult for us to put in the AC maintainer. And in the video, it was quite obvious that you're struggling a lot because the eye was soft.
Yes.
And putting an AC maintainer through a soft eye can itself cause descendant membrane detachment, other problems. Correct. Otherwise, thank you very much for sharing your complication. We learned a lot.
Dr. Deepak, in that case, can we use the other side port to put the AC maintainer?
Obviously, we can do that. Maybe it was
so snugly. We can just put it in.
Yeah. And if he's using the same side port which is using to make the side port incision, it should fit in snugly, actually. It should fit in snugly.
I think perfect analysis, and I agree completely with Dr. Nito about the first mistake is not dividing the nucleus. I call it domino effect. You know, many times we try to find mistake at the time when rent happens, but the mistake has started long back. I think we'll start with the next video now, and the next video I already shared the list is Dr. Shivaji. And Professor Al-Khatani will be asking the question. Okay, so here is the
Hello friends, I'm doing a routine case with NS grade 2 cataract with thick posterior subscapular cataract. I'm doing rexus with Utrana forceps. Rexus is of adequate size and it's round and central. Now I am doing hydrodissection. I am lifting the entry capsule and pushing the fluid. I did not see fluid way passing across. I am doing it on the other side. Suddenly ACs become shallow, iris started collapsing out of the wound and suddenly pupil become small. I thought the fluid must have trapped behind the lens. Now eye is a bit hard. Just tap the lens center so that the fluid trapped behind the capsule can escape. Now putting visco. Now the pupil is larger size, round, larger, dilated, and everything appears okay to me. I am rotating the lens with the dialer. It's not rotating easily. See what I am noting now? Clear space, clear red glow. That indicates the PC is ruptured. There is no PC. Immediately I dived the lens into the entry chamber over the rexus, converted into SICS, making temporal scleral tunnel, removed with Vectis, did some anterior vitrectomy, removed the leftover cortex, and did some more vitrectomy, placed the rigid lens over the rexus, constricted pupil with pilocarpine. Now putting some tricot, dilated tricot, just to sex any vitreous strands, giving wash. It's okay now. Now closing the wound with single suture.
Okay, so over to you.
Yes, Dr. Shivaji, do you hear me?
Yes, I can hear you.
Yes, it is. It was a nice surgery. My question to you is, what is the mistake you did in this surgery?
I think I did not assess the case properly. Maybe
tell me specifically what was the mistake that you did or you did not observe?
No,
Okay. I think Shivaji, we cannot hear him. Maybe he has lost the connection.
Dr. Shivaji?
Until he comes back, we can probably keep discussing.
Yeah.
Connection is problematic, I think.
He lost the connection there also.
I think
the
my
case.
my question to Dr. Shivaji, because he missed in the beginning a fluid wave. There was a clear fluid wave, but he did not see it, and this is a and he continued to push fluid from that side. The most important thing in FACO is the power of focus and observation, and this is what differentiates from FACO from non-FACO. So what he did was did not observe. Most important is, to, and I was going to tell him to decompress the anterior chamber. This is something which I learned from David Chang, which is a famous phacosurgeon. Always decompress the anterior chamber from viscoelastic and do the hydrodissection. If he missed the wave, so he continued, and then he missed the first alarming sign. And this is the problem of phaco. If you miss the first alarming, you go to the second alarming sign. So
Correct.
increase the pressure, and iris prolapse. And then the other alarming sign was inability to rotate the nucleus. But he managed the case nicely by the end. And this is something which I like really, and I like in my Indian colleagues. They are well versed to do. They have the backup ready to do as a phaco. They are really excellent. So he managed it excellent by the end of the procedure.
Am I audible now?
Yes,
Okay.
yes, Shivaji.
Yeah, first I observed that fluid wave not passed across.
But you said it. You said there was no fluid wave. Me as an observer, I saw the fluid wave. So you continue with pushing the fluid, and that's why you get too much pressure in the eye and iris prolapse, which was followed by other alarming signs. You could not remove the nucleus, and these are steps. You know, the problem of phaco, the worst thing about phaco is that the successive step depends on the previous step. But
Yeah.
by the end, I like your way of managing this case. You did it superb by doing the CSIS and finishing the case anterior vitrectomy. But the message here, the take-home message, is phaco is a power of observation and focus.
Sourabh,
Perfect. Yes, sir.
you have been a trained VR surgeon. In this case, I think the story is not still over. Like, you may probably put a lens, but still, do you think that there'll be some droppings of cortex or some material that is there? In that case, what would you be doing?
I think cortex we can really not do much about. I think Dr. Shivaji was quite able to take out the entire nucleus. Many times the issue comes when you have started phaco and created pieces, and then there is a rent. Then some pieces may drop down. I think Dr. Shivaji, you took out the entire nucleus. I think in this case.
Yes, sir. I did converted it to SICS and took entire nucleus. Then I did vitrectomy, remove the leftover cortex. Then I placed the rigid lens for the back.
It's about the fine cortex, 1 or 2 pieces. What will you do it?
So did you remove the fine cortex also? Because Dr. Krishna Prasad is not going to leave you unless you leave that,
No, I have removed all the cortex, but that was not shown in the video.
No, not that. No, I'm not saying anterior from
You
the
mean
anterior segment will be removing.
Yeah.
There are a few droppings which
Yeah.
you see post-op. I'm asking the VR surgeon here, Dr. Sourabh,
Yeah.
what you will be doing.
No, I think for cortex, generally we start the patient on the steroids, and most of the patients do well. If it is a nucleus piece, then we are more worried because there is higher risk of inflammation and posterior segment complication. For cortex, I'm not that worried. So if the anterior segment surgeon has done good anterior vitrectomy and removed most of the cortex, it's fine. If little bit is there in the vitreous, I think it will get absorbed. Okay, so
Sir, one question. If surgeon is not well versed with SICS, then how to proceed with such case? If he only knows phaco.
This is I can comment on this. This is one of the problems sometimes you find in training centers where they just teach phaco. But generations like us are well versed with extracapsular. we can do the extra capsule right away. So it is really important to have the backup plan, which is, I think, in India it is there.
Perfect. So let's move on to the next video by Dr. Sashu Mohan, and Dr. HMR, you will be the judge.
Posterior polar cataracts are challenging even for skilled cataract surgeons due to the high risk of posterior capsule rupture and vitreous loss during cataract surgery. In this video, we will describe the necessary precautions to be taken to prevent and manage such complications. Identification of the posterior polar cataract on dilated slit lamp examination. We should aim for a capsular rhexis size of around 5 mm. A larger rhexis may not leave adequate space for a sulcus fixated IOL in case of a posterior capsular rent. The rhexis should also not be too small. Hydrodissection should be avoided as it may cause hydraulic rupture of the posterior capsule and a nucleus drop. Only hydrodelineation is done, creating a cushion of epinucleus and an endonucleus which is easily phacoable. It is important to avoid nucleus rotation as it can lead to a posterior capsular rupture. The technique of nucleus management depends on the grade of the cataract. For soft cataracts, adjacent trenches are created in the nucleus to create a bowl which is then emulsified within the cushion of the epinucleus as seen here. For harder cataracts, step-by-step chop in situ and lateral separation technique can be used. Slow motion phacoemulsification with low aspiration, low infusion and low vacuum parameters are preferred. An important caveat is to inject viscoelastic from the side port whenever the phaco or irrigation aspiration probe is withdrawn from the eye. Major fluctuation in anterior chamber should be avoided. The epinucleus is stripped 360 degrees from the capsular fornicis before approaching the centrally attached plaque area to avoid loss of epinuclear or cortical matter into the vitreous. The central plaque is left intact till the end. It is then slowly stripped and aspirated in a controlled manner. The cortical matter is removed in a similar fashion. In the event of a posterior capsule rupture, dispersive viscoelastic should be injected from the side port to coat the rent before withdrawing the phaco probe tip from the eye. This helps in tamponading the vitreous and preventing its entry into the anterior chamber. The infusion bottle should be lowered and a bimanual vitrectomy with or without triamcinolone with low suction and high cutting rate should be done for removing the vitreous completely from the anterior chamber. A bimanual irrigation and aspiration should be done for removing any residual cortex. The intraocular lens in an eye without PC rent is carefully injected, taking care to avoid the posterior capsule during implantation. IOL implantation in eyes with PC rent depends on the size of the rent. If the rent is small, it can be converted into a posterior capsular rhexis and a foldable IOL can be implanted in the bag. In case of a large rent, a sulcus supported 3-piece IOL is implanted. An optic capture is done to stabilize the IOL and reduce contact of optic with the iris. By following these 10 tips meticulously, excellent outcomes can be obtained in patients with posterior polar cataract.
Hello.
Dr. Ravindranath, yes.
Yeah, this is not with particular to any single complication or a case. So because it was it related to posterior polar cataracts. So I would like to ask out of all 10 precautions, if you want to shortlist 3, the most important 3, what precautions you should take to prevent the complications in PC rent. Important thing in PC rent PPC is you have to somehow avoid the posterior capsular rent. Or if there is a existing rent, you have to prevent the loss of nuclear remnants or nucleus. So what 3 important precautions will you take? And in this video, did you miss anything in particular in nuclear emulsification step?
So we should avoid hydrodissection for sure, so only do hydrodelineation and avoid nuclear rotation. And also make sure that we're always putting the AC, always formed and PC is not tenting up because that might lead to a PC rent. So these 3 precautions can help you prevent a posterior capsular rupture. And in nucleus emulsification, we can do an inside-out hydrodelineation instead of a normal hydrodelineation. And for soft cataracts, like shown in the video, we just adjacent trenches and we can remove it. There are different methods with many authors, many people have used for the emulsification of phaco. So depend on lambda technique, different techniques have been used.
Unintentionally, probably you have just missed out lowering the nuclear bottle height.
Yes, lowering bottle height. Yeah.
Probably should have mentioned, you know, yes. It, but should have mentioned it. If I am given 3 chances to tell what are the 3 important out of 10, I would first tell modified hydro and no rotation at all in any stage.
Yes.
Not only in any stage, even during phacoemulsification, better not to rotate. If you have a moderate cataract, you can divide and do a in situ phacoemulsification. You don't have to rotate it. Once you divide into two pieces, you can take out after lateral separation. Orient your phaco hand piece along the axis of the longer axis of the nuclear piece, and slowly take it out of the bag, and you can emulsify at the level of capsule or iris. Second important is slow motion phaco, where you just imagine everything is going slowly. Your power, your flow rate, your bottle height, your pressures, your movements, your thoughts, everything should be very slowly and cautious. And third is very important is you have to maintain the transcapsular gradient 0 or very minimal. So never allow anterior chamber to collapse at any stage of a surgery. I think if you manage these three things, you can get away with good outcome. Only thing is we should not lose nuclear remnants and nuclear PC rent to happen, because once PC rent happens, so all things will change. You will not be in a position to put the IOL in a desired place where it is supposed to be. Even if you put in the sulcus and do a capture, it again a compromise. You have to be in the back, so better to prevent the complication. And if there is an existing PC rent in a PPC, usually, unless you are very vigorous, intercapsular highlight will not break. So you can easily get away if you do a slow motion phaco.
Thank you, sir.
Fantastic. Dr. K.
Yeah, I think very nice to see a young surgeon showing the very important case of PPC. Dr. Shashvati, I think normally people show very soft cataracts and the nucleus emulsification will be a non-entity most times. But not always. We do have sometimes harder nucleus. I think the rhexis, you showed a nice round 5 mm rhexis, probably can work against us because we cannot break it into 4 pieces.
Yeah.
We can make it into 2 pieces max. So the best would be to have a more oval, vertically oval rhexis, so that we can just hold it on and try to, position it slightly out of the. It's easy to take it out of the, rhexis and emulsify it at the rhexis margin. So maybe oval rhexis would be a good idea.
So this is one case where examination of the operated eye, if it is operated earlier, very important to examine the previously operated eye. If there is a PC rent, you can probably suspect if it is a mature cataract. If it is visible, it is fine. But if it is a mature cataract, other eye has a rent, probably in back of your mind, you can keep the possibility of a posterior capsular PPC in these cases.
Yeah, I've actually had a case like that, sir, where the other eye was a mature cataract and this eye had a PPC. So I did an SICS in that patient because I'm more comfortable with SICS at this stage. At this stage, and still on beginner stage of phaco.
Yeah, I think
so
Dr.
the patient was doing well after surgery. So.
Yeah, I think one discussion I think I had with Dr. Deepak, and one of the points that we discussed was that during PPC, as far as possible during regular phaco also, if the entire eye is kept in its normal anatomical position, that means the AC should not be too deep or too shallow. I think the surgeries generally go without any complications. So in PPC, rather we will be, more keen on observing that the anatomical position. Dr. Nito would he has some amazing techniques, all surgeons, think this way, and Dr. Nito thinks in another way. So I would like him also to comment on his technique of posterior polar.
No, I wasn't really going to comment about the technique per se, but I think one of the most important things that the surgeon has to do is to perform a perfect rhexis, because this is the thing that will allow you to, let's say, save the surgery in case of APC rent, because with a good capsular rhexis, you can, if necessary, perform an optic capture, very safely place an endosulcus IOL and optic capture the IOL. So it's a most important thing in a posterior polar cataract to do that. And it's not always easy because many or most of these patients are young ones. And the surgeon must remember that the capsule behaves differently. And it's a very common It often, frequently, the opening gets bigger than the surgeon wants to because of the elastic nature of the capsule. So it's very important to have this in mind.
Yeah, just to add on to what Dr. Nito said, there has been a study which clearly states that the incidence of PC tear is significantly more in patients, younger patients who have PPC compared to patients who are slightly elderly with PPC. I believe the single most important reason for that is the scleral rigidity. The sclera is slightly elastic and you have an opportunity to overinflate the eye. Most of my posterior capsule tears are because of overinflation rather than underinflation. And because in these younger patients, the sclera is more elastic, you have you don't have a control of how much fluid you're putting because the eye accepts. And that is that is a reason why you can break the PC even during the last step of surgery while doing your stromal hydration. You just inflate, and then at that moment it can just rupture. So overinflation, be cautious, especially in younger patients and myopes.
Perfect.
Last question. No, she said SICS versus phaco. What is your choice in a PPC where you can do both?
Again, I think
you are just back from a debate, right?
No, it is. It's purely goes with the surgeon's skill level and the confidence he has and the command he has over each technique. If both the cataracts can be removed in either technique, purely it's his skill and confidence of that technique. Yes, it's good enough because of low pressure surgery. Next case.
Okay, over to next video. Dr. Shiti, you are ready? Thank you. Here you go, Kshitij. You can start your own.
Phacoemulsification in an intumescent mature cataract. The capsule was stained with trypan blue and cohesive viscoelastic was injected in the anterior chamber. As soon as I start maneuvering it, the rhexis extends again and boom! I have a equator to equator rhexis extension, what we call as the Argentina flag sign. The Argentina flag sign occurs because of increased intralenticular pressure, and aspiration of the loose cortex would probably have been a good idea. Moreover, I feel that I should have given a nick with the capsular rhexis forceps before maneuvering it the other way round. Now that I have this complication, I give a nice round and large rhexis. I begin with phacoemulsification by aspirating the loose cortex. While doing the nucleotomy, it needs to be ensured that all the maneuvers are gentle and excessive lateral separation of the nuclei should be avoided, for it could cause the rib to extend and cause a posterior capsule rupture. Low parameters should be made use of with a moderate flow rate and a low bottle height. The anterior chamber should not be overzealously filled with viscoelastic, nor should a sudden decompression of the anterior chamber be allowed, because a sudden fluctuation could lead to extension of the rhexis and it could culminate in a posterior capsule rupture, which could also lead to a nucleus drop. The nuclei are partially delivered in the anterior chamber and are emulsified at the pupillary plane. Cortex is removed by bimanual irrigation aspiration cannulae. While dialing the IOL, care needs to be taken that all the force that is exerted is tangential and there is no element of posterior force, because it could lead to an extension of the rhexis. Haptics need to be tugged underneath the intact capsule away from the extended rhexis margins. I believe then the Argentina flag can be successfully conquered.
Am I audible?
Yes.
Yeah. Hi, Kshitij. Congratulations. You did wonderfully well. If given a second chance, if is there anything you would like to have done differently? This is after it has gone radial. I'm telling you, it has gone radial. Any other thing would have slightly done differently in this case?
if given a second chance, then I would have probably liked to aspirate the cortex after giving the first nick for the capsular axis.
Yeah.
So that would have probably prevented the capsular axis running radially. And the other thing which I did wrong in this particular case was that while initiating the rexus from the other side, I didn't give it a nick with the scissors, with the intravitreal, with the capsular rexus scissors. I tried to manipulate it using the capsular rexus forceps straight away. So I feel if I would have given that nick, then the control would have been much better over the capsular axis.
Okay, that's great. You did a wonderful job. Dr. Sourabh, can you just pause the video at 16 seconds, 15 seconds or 16 seconds? I'd just like to show you a clip where I felt you could have done it better.
This inauguration of the loose cortex, aspirating the loop needs to be ensured elastic was injected in the anterior chamber.
Yeah. At this moment, I'd just like to highlight that you are injecting the cohesive viscoelastic very close to the opening of the your capsule opening, which you've done here. See, this tear is still intact. You could have still saved. You were still not there. What you did was you injected the cohesive OVD just under the flap or around it. Some amount of OVD just gets into it. It raises the intraocular pressure again, and it has gone both ends out. There was a momentary chance of probably retrieving at that point. That is what. And otherwise, as your second time told, you could have decompressed at this stage itself, decompress the back. A third point I would like to do is, although things went off very well, one additional point is once you do a chop, there should be no rotation of the nucleus cell. And once you do a first fragment, I would always like to take out the first fragment out, emulsify it, rather than continuing to chop all the fragments. What it does is it creates some extra space in the bag once you remove the fragment out. Because once you've removed the fragments out, further nuclear divisions when you do, it's not going to induce much stress on the tone edge of the capsular flap. And the last point would be, I'd always like to keep an eye on the flap motility sign. If the flap of the tone edge is always turned anteriorly, you are a little bit sure that it has still not entered past the equator to go into the posterior capsule. So the thing is, never inject viscoelastic in the vicinity of the tear. It has to be injected at the peripheral of the chamber, Next, when you do the chop, and I would like to always remove the first quadrant so that you're creating space, then the amount of stress being induced on the torn edges is slightly limited. And third, and most importantly, always try to keep a watch on the edges of the flap. The moment you feel that it is stiff and it is not fluttering and it has become inverted, that is the time for us to convert. These are 3 points. Excellent. Any other judges, please can comment.
Yes, Dr. Deepak, I think it was really managed well. But one of the comments here in these cases, I think as a technique, Seiko chop is the best because you will hold it in the center and then you will divide it. And as you said, mechanically get the first piece and then. But for just a general comment here, our psychological perception about extension of the tear is more than reality. But still, I believe when the cataract is harder, it is safe if you want to go back to small incision or ECC.
Agree. Perfect.
In these intermittent cataracts, I usually do a double rexis.
Yes.
Initial small 3 millimeter or 4 millimeter rexis, which is easier to do. Usually, you don't lose it. Once you do it and thoroughly decompress the lens, and then make a nick and do a second rexis, it works wonders. Most of the times, you will not lose rexis.
Yes, I think a couple of techniques are quite good. I think two-stage rexis that I've seen Dr. Deepak also and Dr. Pradeep Mohanta sir also do it quite often. And also the second technique is doing the aspiration of the cortex one way or the another, decompress, and then. So I think we have to prepare the eye for the first nick before we start going for the complete rexis, and that's the I think take-home message. Wonderfully managed. Here, I would like to present one presentation from our sponsors, Novartis. We have been kindly sponsored for this educational event by Novartis as well as by Mr. Ajay Mahajan of Cardio Care, who makes instruments for us. So I would say he is instrumental to us. So I would like to quickly share one presentation on Ilivro, and then we'll go ahead with, there are some fantastic videos. The next video is going to blow your mind. So just let's start with this small presentation. And this is about keeping the cystoid macular edema at bay using the Ilivro. As you know that CME is one of the major complication because it is going to reduce the patient satisfaction after cataract surgery. And there are, a lot of risk factors. In our patient group, we see clinical CME in 2% patients, but it may be there in almost 20% if we tend to do angiography to detect that. And the main cause of this CME is the inflammation, that is the breakage of the blood-brain barrier. And normal time when we see CME is the acute phase, that is within 4 months of surgery. But sometimes in certain cases, we also see in late or chronic stages also. And the main the effect that we see clinically is the reduced visual acuity and contrast sensitivity. So if any patient post-operative period is complaining of reduced contrast, reduced vision, or metamorphosia, I think we have to rule out CME because that is treatable, and if treated in time, it might save the vision well. And of course, patient may have other risk factors, particularly in our country, of course, worldwide is diabetes and other systemic diseases, as well as some pre-existing ocular conditions like uveitis. And of course, if we do any complication during surgery, there is always an increased risk of CME. So diabetes and hypertension are known risk factors. So are retinal vein occlusion, glaucoma, uveitis, and already present epiretinal membrane. So here I would like to emphasize that every cataract surgeon, irrespective, even if you see grossly that the retina is normal, I feel they should undergo OCT to look for any microscopic changes which you might otherwise miss, and that sometimes detects those early cellophanes, early ERMs which otherwise you may miss. So all these complications that we are going to see during this webinar are going to cause increased risk of this CME. And diagnosis, I think apart from all this, I think OCT is the main investigative tool for diagnosing CME. In fact, any patient after 1 month, if he complains that there was some change in vision, I ask the patient to undergo OCT to look for any subtle changes in the macular thickness. Management of CME, I think prophylaxis has done wonders. Like since we started using NSAIDs pre-operatively, and of course post-operatively, the incidence of CME has reduced drastically. And of the NSAIDs, I think nowadays what I commonly use is the Nepafenac. I think that's the most commonly used NSAID by almost all ophthalmologists because it's quite effective. And what I like about this particular molecule of Ilivro, it also has the Nepafenac, but it gives you a once-a-day dosing. And as I've noticed that whenever I tell patient that put this drop 4 times, invariably, most of these patients are not that compliant and they will put it maybe 2 times. So for once-a-day dosing, I think has immense use clinically, and it has the same active ingredient like Nepafenac, and it has a suspension that increases its working time. And I would like to also discuss with other judges that what is their routine regimen post-operatively. How long do they give NSAIDs after a routine case of phacoemulsification, and do they change their regimen for particular cases? So Ilivro, the best thing is that once-a-day dosing, and it is as effective as the Nivanak, which has to be used 3 times a day. And that's the part from the Novartis and Ilivro. So I think there are studies which have already shown that even the once-a-day dosing of Ilivro is quite effective in reducing the incidence of CME as well as treating the cystoid macular edema. And particularly in diabetics, I tend to give it for slightly longer time, say around 8 weeks, and it definitely has given much better visual results in my patients. So definitely this is one of the molecules that we'd like to look for. So just a small question to all the judges, that what is their routine regimen for NSAIDs? How long do they give it? And I know there are genetic, differences, like Indian patients may behave slightly differently to cataract surgery as compared to, patients from other countries. So Dr. Nito, what is your usual regimen for your post-cataract patients?
Well, I usually start steroids and non-steroid anti-inflammatory agents 1 day prior surgery and continue usually up to a month. The non-steroid anti-inflammatory agent, we keep up the same regimen during the whole month or 3 times a day. And the steroids, we commonly use 4 times a day for the first 15 days, and then twice a day for more 15 days. We have to do, you have to understand that I do surgery for the public health system, and they're very poor patients with poor education, and we have to simplify the regimen for them to follow. So I firmly believe that there are much better regimens of administration, but we use this one because it's very easy for them to follow. We even provide them the medication. We prepare for that because it's most important for our patients for us to give, because many or most of them don't have the money to buy it.
Dr. Mohanta sir, how long do you give NSAIDs post-operatively in your patient, and what do you think is the incidence of CME in your patients?
I start. Hello, am I audible?
Yes, sir.
Yes.
Yeah. I start Nepafenac 1 week after surgery. The antibiotic that is we start before surgery continues for 1 month, 1 week. We stop the antibiotic after 1 week and then start the Nepafenac, because that decreases one more drop.
Okay. And how long do you continue?
Yes, I continue Nepafenac for 6 weeks.
6 weeks.
Yes.
Okay. Any other regimen that for Nepafenac, anyone gives it for longer time or shorter time? Or 6 weeks is the general consensus. Okay, thanks a lot. So now let's move on to the next, Dr. Lalit, and I'll be sharing his video now.
Today I'm showing a mature cataract, side port, main port entry made. So you can see milky fluid coming out from the bag. Capsular is done by using Rexis forceps, and you can see a leathery brown cataract, seems to be quite hard and mature. These kind of cataracts are usually very slippery, so you have to hold them properly. I'm trying to engage my phaco tip along with chopper so that I can divide the nucleus into small pieces and phaco emulsify them. While doing the maneuver, as there is no epinuclear support, I got the rent. See over here, there is a small rent I have noticed. Immediately I stop my phacoemulsification and inject viscoelastic. And my plan was IOL scaffold technique, but all my effort to bring that nucleus from anterior vitreous over the IOL was fail. I was trying with 2 blunt tip choppers having long tip 1.25 millimeter. So all my efforts were fail to bringing back that nucleus, rescue that nucleus. So I insert the another haptic into the sulcus of the IOL, and then from a 26 gauge needle from pars plana, I engaged the nucleus, which was freely moving into the anterior vitreous, and from other hand, with the help of a chopper, I pushed IL in downside and tried to bring back the nucleus above the IL. I engaged the nucleus with a 26 gauge needle, and in this maneuver, I was successful in bringing back the nuclear segments. After doing vitrectomy, anterior vitrectomy, rest of nucleus was phacoemulsify above IOL. As there is no cortical matter, so hardly any reaction was there after surgery, and patient was having very good vision after surgery. Thank you.
Hello, am I audible?
Over to you, Dr. Nito. And before Dr. Nito, you can unmute yourself. Where is Dr. Lalit? Please start your video, Dr. Lalit.
Yes, sir.
Yeah, please start your video. Okay, before Dr. Nito answers, I would like to complain against Dr. Lalit. You know, I am a retina surgeon and he's not giving me any work. You know, from my, vitreous, he took it out. I'm unemployed because of him. So, Dr. Nito, please.
Well, my question...
Sir, my video is not working.
Okay, fine. Okay, no problem.
Sir, you have to, yes.
Yeah, perfect. Yeah.
Okay. Well, my question would be, why did you did not get the nucleus out of the bag before implanting the IOL? Why didn't you bring the nucleus, the remaining nucleus, to the anterior chamber before implanting the IOL?
So I tried to move the nucleus towards the 12 o'clock position and away from the posterior capsular rent. But during that IOL implantation, my posterior capsular tear ripped off. It increases in size and nucleus suddenly start hanging to the anterior vitreous. So I thought I have already secured my nucleus on 12 o'clock position before injecting that IOL, but either because of a lot of visco inside the anterior chamber or like what happened that IOL hit the posterior capsule and I was having big giant tear rent of the posterior capsule.
Dr. Lalit.
Yes, sir.
What could have been the alternatives? IOL scaffold is nice on the paper. It's a good, theoretically good, but it has its own practical effect. What could have been done differently instead of IOL scaffold?
So one possibility is I can enlarge the main incision because it was just heminucleus. So my main incision was around 2.8 millimeters. So by enlarging to up to 4.5 millimeter, then that nucleus can be bring it by using a kind of like a small incision cataract surgery, and IOL can be implanted from that.
Oh, we have a lot of excellent, OVDs available now, which can actually seal the rent. It can create a platform on which you can emulsify the nucleus in the anterior chamber safely because it's a smaller one. And instead of putting an IOL scaffold, you can create a viscoelastic scaffold, which is very much possible, and that makes the whole equation very simple. IOL scaffold is more like a, it probably has to be tried by experts, and it has its own variations and a lot of new variables you add in. Like in this case, there's a very excellent video that you have really recorded very well. But definitely, even though you have made Dr. Sourabh, unemployed, but soon he may probably get into like the patient because of the anterior vitreous manipulation. You may still create some tears in the retinal periphery, and you may give him a bigger job than removing a nucleus, maybe a proper full-fledged VR surgery.
That's true. But I think, Lalit, what I was seeing, during this video, there were no tremors in your hands. No tremors at all, If we get such kind of complication, our hands shake, but you are so rock steady. I think the credit to your, good temperament. Yeah, Dr. Professor Al-Khatani.
Yes, Dr. Lalit, I think again we go to the alarming signs. This is to be a hyper mature cataract with no cortex. So the minute you raise the nucleus, I saw a very nice red reflex. So I have to create an artificial cortex, which is thick viscoelastic, or I will put an IOL scaffold technique, and then I will be relieved doing the phaco above the IOL, or use a thick viscoelastic. I agree with Dr. Me too, that that piece, which is about a quarter of the IOL, could have been raised before putting the IOL.
Dr. Deepak, you would like to give tips on prevention of this particular complication?
Yeah, I think one or two things. As Dr. Neto rightly pointed out, there was an opportunity for you to bring the nucleus out, but you had enough faith that the pupillary, the posterior capsular rent would not extend, so went ahead. Because the most common reason for the PC tear to enlarge is during the IOL implantation itself. If you don't have a rhexis there, if you're not able to do a posterior capsular rhexis, it is going to enlarge when you're trying to put your IOL. So the message here would be, you have to segregate it not in the bag, but segregate out of the bag. Pull the nucleus out of the bag, place it in the iris, maybe a little bit far away. Then try to place the lens in the sulcus rather than in the bag. So once you have the lens in the sulcus, the IOL, the lens matter above the iris, and then you push the lens matter again back onto the surface of the lens and then continue. Otherwise, other option would be, as Dr. KP has already said, you could have used dispersive OVD to do the job itself. Another option, as Dr. Al-Khatani said, use an IOL scaffold technique at the beginning of the surgery itself. So multiple variations, but you are daredevil, you know, you could, very, very astonishing to see that you got the idea that you could push the nucleus out from behind the lens, behind the PC, and push it out. That is an, your mind is working even at that stage. That credit goes to you.
Thank you, sir. Thank you very much.
Yeah, I think excellent contribution. I think, but I must here mainly what I feel, which I learned from my father. That we have to think, little differently. We are thinking from the point of view that what will patient say to me if, I refer this patient to a VR colleague. He will say that you are a failure or you have done a, bad job. My father started phaco surgery in 94, 95, and there was no vitreoretina surgeon in a 300-kilometer area, around town. And of course, just like as you are learning, he also had a nucleus drop, and he's not nucleus drop the same way, rent, and the piece was dangling. He sent that patient right away to the nearest, VR surgeon, almost 300 kilometers away, and patients, I could be saved. So I frankly, at these points, you have to really think from patient's long-term point of view, and patient to a VR surgeon and take good care of, his eye. Really, that's what I feel. You have got really great skills. I've seen so many of your videos. Amazing. But these are the points where, you have to stop somewhere and, take a right decision to send the patient.
Sure. Thank you, sir. Thank you very much.
Thank you so much, Lalit. And over to next video by Dr. Lakshmi. Yeah, okay.
An amputated IOL. After IOL implantation into the back, decentration was noticed. On dialing the IOL, it comes to our notice that one of its haptics is amputated, probably in the injector. The incision slightly. The unharmed haptic was exteriorized. The IOL optic was cut in the center and explanted in two parts. Inverted IOL in the bag. After IOL implantation into the bag, it was noticed that the IOL was upside down, inverted S configuration. IOL was flipped using irrigation aspiration probes to bring it to correct position as it is. But in case of aspheric IOL, multifocal IOL and toric IOL, it needs to be flipped back into place. IOL stuck in the entry wound. First thing to do here is to protect the endothelium with ample viscoelastic substance. Wound is carefully enlarged. The IOL is gently pushed with the aspiration probe and dialed into place. IOL not releasing from the injector cartridge. We can see here that the IOL's trailing haptic is stuck in the injector. In such a situation, the injector's piston has to be taken back and pushed again, but gently. Otherwise, the pressure on the haptic-optic junction will cause the haptic to break.
Okay, thank you so much. And yeah, I'm supposed to ask you a question. Dr. Lakshmi, can you tell me one thing which you can do to avoid all these complications? Only one thing.
Probably do an SICS and put a PMML in. Whenever we are injecting with a phaco injector, these things happen. I mean, it's not intentional, but sometimes there's a manufacturing mistake. Sometimes we don't inspect while putting it in, or even after putting it in, it might break in. So the one thing that I would like to say is while injecting it into the cartridge, you have to make sure every part is fine and to put it properly into the cartridge and then inject it, I guess.
Yeah, perfect. Anyone else would like to also
Load
add
under
comment?
microscope. Load under microscope. That's all.
So I think, you know, in phaco surgery, I think injecting IOL is one engineering job, I would say. You know, here we have to have a mental checklist, whether you are holding the IOL well, whether you are using the, right OVD or BSS, whatever, whether you are putting it properly in the cartridge, whether you are, if it is an open cartridge like butterfly, whether you are closing it properly without, getting stuck, whether you are pushing, and while pushing, whether you are, observing if the trailing haptic is getting jammed or the leading haptic is going smoothly, then push, pull outside to see that it is going smoothly. Usually it gives you indication when you are injecting. Okay. And then while injecting, also you have to keep on observing if it is going as per the plan. Just like, these airlines have this checklist. You must have read about Checklist Manifesto by Dr. Atul Gawande. Excellent book, So I think whatever complication, I think all of us had these kind of complication with iOS. And most often it happens when the IOL is new in the market, or you are using it for the initial period where you are not knowing what can go wrong with that IOL. So I think a new IOL is like a new challenge to you, and you have to go through all these engineering nitty-gritties, right from whether you are using the right cartridge, even the temperature. Some of these hydrophobic IOLs, they get so hard with cold temperature, they don't bend, and then they get stuck in the wound like that. Okay, so I think it's the engineering little bit of knowledge that we should have. And another thing I would like to add here is that every cataract surgeon should know how to explant the IOL from the same incision. That is a very excellent skill to have, because then you are not worried about anything happening to any IOL, and you become a much better cataract surgeon. You are not, worried about IOL implantation, and you can learn it in the wet lab very easily. So if you have a wet lab around, you can just put these IOLs come very cheap. Sometimes the representative may give you a, sample IOL. You put it in, you try to cut it and take it out. If you practice is enough in the wet lab, on table, it becomes very easy. Otherwise, what most youngsters, end up doing is that they enlarge the incision and take the IOL out. Okay, but that's not the thing we should aim for. Go for the IOL cutting and removing. Okay, Dr. KP.
Yeah, I think this happens when the IOL is new in the market or the surgeon is new in the market. Rarely when the surgeon is too old in the market also. Because we think that doing the nuclear emulsification is the job that we need to do, and we normally lose some focus during the last part. And many a times we inflict a lot of damage to the intraocular lens surface. So I think that is very important. So atraumatic handling of the IOL and a very meticulous insertion is probably the icing on the cake, which should never be forgotten even by the senior surgeons. Thank you.
Thank you so much, sir. Okay, so next we have. Okay, I will just play the next video. Thank you so much, Dr. Lakshmi. Dr. Amit, you are next, and Professor Al-Khatani, you will be.
Hello friends, I am Dr. Amit Mahajan from Om Netralay Chalisgaon. Now I have to implant panoptics, so I have inflated back with the good visco, and I have loaded it in the D cartridge. It was Alcon D cartridge, and as you can see now, suddenly I noticed some resistance, and I came to know that my cartridge was out of the wound. And see what happened. I was stuck inside the wound because 2/3 of the lens was inside the chamber. So I thought I have to just push it inside the chamber and it will go easily inside. But that was not the thing. So then I inflated back with the visco, and then I tried to pull it outside. But see, it was not. Neither it was going inside nor it was coming out. It was not going inside, not coming outside. So then I tried to compress with the forceps and then just to push or to pull, and somehow it came outside. But see what happened. While bringing it outside the chamber, I have broken the haptic. Either I have to keep the patient aphakic or I have to put any other monofocal lens. So I have decided to go for a -0.5 correction monofocal lens, because to keep the patient aphakic for 1 or 2 days was not possible for me, and backup lens was not for me. So the biggest lesson I learned here is to always keep one backup lens with you before proceeding to the any case, maybe it multifocal or monofocal, one additional lens should be with you.
Thank you.
Dr. Amit, you can start your video. I will just check. Where is Amit? Oh, I think he lost his connection. Oh.
No.
Yeah, okay. Can you start your video, Amit?
I think host has stopped my video.
Okay, I will start. Okay, fine. Just check now. Okay, Professor, you can start asking.
Thank you, Dr. Amit, for this nice surgery. Before having a backup of a lens, my question, what would you have done if you go back to do the same procedure?
See, this patient was for multifocal, and why I made this mistake is because I was just a bit relaxed that I have finished all the case, and with that relaxed mind, I forget to keep proper concentration while loading, while implanting the IOL. So at that point, I realized that my plunger was overriding the haptic. So I just tried to pull it little bit and again push it. But while doing this maneuver, my cartridge came out of the wound, and that's why I left it IOL.
So what would you do next time? I mean.
No, I have implanted many acrysops, and I have never come across such type of situation like before. Why I am sharing this video is because just two things: that one should not relax until the case is finished, and the other thing, one must have the backup lens, because the other I implanted was the multifocal, and this case was also for the multifocal lens.
Okay, let me comment on your management, by the way, was excellent. But I noticed in your left hand was the IA, which is good for supporting. So, but the problem, you lift the pressure by the end before inserting the intraocular lens. So you have to keep the pressure constant so that all the lens inside the chamber. Although I am not in a favor. See, most of the time we want to be perfectionist. I'm not personally in a favor of wound assisted. I feel it is traumatizing to the wound. What I do, I enlarge the inner side of the lip slightly from both sides, and then I introduce the cartridge, the head of the cartridge, and I inject. And that's it. It is. I feel I'm not a favor of wound assisted. But if you want to make the wound assisted, then you have to keep the same pressure till you see things are inside. All.
Perfect.
Amit,
And yeah, Dr. Deepak.
Amit, if I had this complication, I would say that I would straight away say that I would postpone the surgery. Tell the patient that unfortunately the lens has broken, so we'll just wait for 2 days, get a new lens and put it back. Because having the other eye multifocal, I don't think it would have been a big deal for the patient to wait. And just tell that sometimes it happens. The lens broke, so what to do? We'll get another lens and then we'll put. I think sometimes better to acknowledge that.
Right.
Because when we look at the longer interest of the patient, waiting 2-3 days, he will be anxious. I will be anxious. You'll be anxious for 3 days. That's fine. But many times it happens. See, toric lens when managed, many times there's a misalignment. We have to go back and do it. Same way it is. Buy some time, then do it. No problem.
In fact, I would like to share here, I think few years back, I had one toric multifocal to be implanted. I had implanted in one eye and other eye I was operating. And here the IOL actually dropped. So it didn't drop inside the patient's eye, outside. The assistant was opening, and it fell out. So IOL dropped. So I did the same thing which Dr. Deepak said. I just washed out the viscoelastic, told the patient that after whatever days the IOL arrives, preferably within a week, I will just implant it. And it was a nice surgery, next time, because patient could really see well immediately after surgery. So I think we can, not stress ourselves with making patient, all right in the one surgery itself. Ask retina surgeons. They do multiple surgeries, and make the patient perfect. Yes. Yes.
Come for the second surgery during first surgery.
Yes.
Yes,
Dr. Sourabh, there was two choices. I was personally in favor of what he did, because taking the patient to another surgery, generally the patient perceives it as a form of failure. And in the literature, there is one eye which has been put trifocal and the other none. So some patients, they accept it. So this is the one choice. The other choice, the patient can put an adds-on in the sulcus in the future if he's not happy.
Perfect. I think I would like to just, we'll move on to next video immediately. Just an anecdote. On my when I joined MBBS course, I had a very famous cardiothoracic surgeon who came for, a lecture, kind of a motivational lecture for, young doctors. And he told an anecdote about his, teacher. And he was one of the first surgeon who started cardiac transplant in India. And he was assisting his mentor, and he told his mentor, if you do this, it this way, it's very easy, to do it, and it will save our time. So what the mentor told is that, see, you don't have to do the easy way, you have to do the right way. So don't go for what you can do easily, you find out what is the right for the patient and do it. Okay. So next video, very, very interesting video. So Dr. Girish Gadre.
36 years female with chronic angle closure glaucoma,
undergone peripheral aortotomy elsewhere twice, and on 2 anti-glaucoma medication, intolerant to acetazolamide, presented with left eye chronic angle closure glaucoma with cataract, with intraocular pressure 48 millimeters of mercury, with very shallow AC and 360-degree posterior synecdoche. Preoperatively, visual acuity was 624. Patient was taken up for cataract plus IOL, trap with MMC. AC was completely flat. So decision was made to make a sclerotomy and anterior vitrectomy to form anterior chamber, which was done. AC was formed with visco, but repeatedly it was getting flattened. So some more anterior vitrectomy was done, and intraocular lens was implanted uneventfully. Rise in intraocular pressure was noted with again shallowing of anterior chamber. Lens was well settled. Then we proceeded for sclerotomy along with a peripheral atriotomy, which was done with a blade. While doing peripheral atriotomy, there was no pressure rise. One can see there is no much iris prolapse, and AC was well formed with retained air, but at the same time one can see white glow in the pupillary area, and that's how we suspected suprachoroidal hemorrhage. Decision was made to close the wound immediately, and because sclerotomy was already formed, we tried to drain suprachoroidal from the sclerotomy. Our diagnosis was correct, and the fresh blood we could drain from the same sclerotomy site. While doing that, we raise intraocular pressure from the side port through the continuous irrigation, which made drainage of blood from sclerotomy site. Then we have taken decision to go in because retina was seen in the retrolenticular area, and so 3-port pars plana vitrectomy was planned. Because suprachoroidal was there on the temporal side, we have suspected it. We have made inferior sclerotomy on the infero-nasal side. When we went in, our diagnosis was correct. There was a large suprachoroidal hemorrhage on the temporal side, which was partially drained. So we have done fluid air exchange, but retina was not settled. So we have made a small retinotomy and done fluid air exchange. One can see retina was very well settled. We did laser barrage to the retinotomy site, and air silicone oil exchange was done. One can see retina is very well settled, and on temporal side there is a shallow suprachoroidal. AC was well formed. Postoperatively, patient did well. We have given systemic steroids, topical steroid and cycloplegic. Postoperatively, visual acuity was improved to 636 with IOP maintained to 10 millimeters mercury.
Hello, Dr. Girish.
Hello, Sourabh.
Yes, I think the suprachoroidal hemorrhage is a very uncommon complication that many of us may not, even see one in their ophthalmic career. So, if you go back in time, what will you, change in your opinion during the surgery, or pre-operatively or post-operatively?
Actually, in this patient, there were no any risk factors for suprachoroidal, like hypertension, patient on anti-glaucoma medication. Even patient's age she is young patient. The only risk factors were patient is having glaucoma. That is the only risk factor. And intraoperatively, I suspect when I did vitrectomy, that time there was a hypotony, which might have induced suprachoroidal hemorrhage. Otherwise, there were no risk factor preoperatively.
Yes, perfect. I think apart from this, I think when you started getting this fresh blood outside, Usually what we try to do is that keep the intraocular pressure of the eye high so that, the
Correct.
fresh bleeding stops. But instead you decided to go in and, try to drain out the fresh suprachoroidal hemorrhage. So why did you take that decision?
No, initially I raised intraocular pressure from side port. If you have seen a video, that from the side port I have continuously irrigated anterior chamber with a fluid and drained the blood. When the drainage of blood stopped, then I took a decision to go in because retina was in the retrolental area. So I thought it's a complete suprachoroidal. I do not want it to go like a kissing choroidals.
Any other comments from Dr. KP?
Yes, sir.
What was the need to do an anterior vitrectomy in the first place? Was it to deepen the AC? I think
Yes,
once you
correct.
remove the lens, the cataract,
basically,
deepens.
yeah, AC
Normally, we don't do it as a routine.
Yes,
So the angle closure
correct.
glaucoma cases. Once we do the cataract surgery, and the AC is fairly good enough. But was there a need to go inside through pars plana to increase the AC depth? What was the actual plan?
AC was completely flat. There was no, I could not inject even visco from side port. I
Why?
tried it three times.
After the cataract
Possibly,
surgery?
I thought, yes, after cataract surgery, AC was, initially also AC was shallow, but it was not flat. After removal of cataract, AC become completely flat. So I thought it is a vitreous upthrust, which might have caused all these things. And maybe it could be a hydration of vitreous which might have caused all this anterior rotation of iris lens diaphragm, possibly like that. That's why I took decision to do anterior vitrectomy.
Suprachoroidal at that point of time?
No, not at all. There was absolutely good glow at that time. Even pressure was quite okay. Intraocular pressure was quite okay. It was not tight globe and all that.
Okay.
Even I have shown that air bubble is well retained. If it is a suprachoroidal, air would have come out from the side port.
Okay.
So I think luckily
Yes,
it was
sir.
not expulsive suprachoroidal
Yes,
hemorrhage.
it's a partial suprachoroidal, and timely, if we would have not done, it would have gone into expulsive hemorrhage, possibly.
Professor
Al-Khatani, yes.
Yes, my question is that when you did the phaco, as I understand, the pressure was 48. Is it? You said?
No, not at all. No, pre-operatively pressure was 23.
So you
We
control
have
the
given
pressure.
mannitol pre-operatively.
Okay.
When patient presented to me at that time, pressure was 43.
I think this case demonstrates that, usually this looked like a classical fluid misdirection syndrome. You remove the cataract and then everything was fine. And you thought the fluid has gone behind the retrolental space. And by just decompressing it, probably you will deepen the chamber. And you never knew such a terrible complication was awaiting you. So pars plana tap should not be taken so lightly. On the hindsight, if I would have done this, if the AC was shallowing, just close it and just leave for another day. Just close it, come back, 2-3 days, it would have to settle down, then put in the lens. But on the handset, everything looks easy. But on that day, it's very difficult. But it's very difficult to manage this complication in the table. And you did it at single setting. Usually, when you have a suprachoroidal, we just close it and come out. But you just decided to tackle it in the same day. Congratulations to you.
Thank you.
I think fantastic surgery. Even in retina, I think he changed his regular influence port to another side so that to avoid that suprachoroidal hemorrhage area, and then settled it later. I think excellent surgery. Thank you for sharing with us. Thank you. So over to now next, Dr. Manas.
This video presentation is on a 0-hour decision making and consequences in a stressful situation. A young female patient presented with defective vision in both eyes since childhood. She has high myopia, superinasal lenticular coloboma with correspondingly absent zonules, and cortical cataract in the visual axis, which was more in the left eye than the right. So I decided to proceed with cataract surgery in her left eye first. Her IL power was 7 diopter. The plan was to do a temporal clear corneal phacoemulsification with placing a foldable single-piece acrylic IOL in the bag with a CTR. As the zonular loss was around 4 clock-hour, even a CTR was enough, but for better centration, I decided to fix the bag with the sclera with a capsular tension segment. So I started with making the Hoffman pocket in the area of weak zonules. While dissecting with the crescent, starting from the limbus, I noticed blood in the anterior chamber as I went too deep inside the sclera. Probably I did not consider the fact that the sclera will be thin in a high myopic patient. A CTR was implanted and the open ends were positioned away from the weak zonules. As everything was going smoothly, a single-piece acrylic foldable intraocular lens was placed within the capsular bag. Unfortunately, one of my iris hooks was too tight and stressed the rhexis margin while placing the haptics in the bag. This undue stretch toward the rhexis margin would extend it further on little manipulation. However, there was no vitreous disturbance. I found myself in a situation where nobody would like to be. So the next thing running in my mind was, how do I manage this further? Should I go for IOL exchange with implantation of a multi-piece IOL? But I did not have the backup of a lower power 3-piece intraocular lens at that moment. Can we fix the same single-piece foldable IOL in position? Well, it can be sutured either to the iris or sclera. But suturing a single-piece foldable IOL to the iris can lead to iris chafing and pigment release. Literature has shown good results with suturing it to the sclera, so I decided to proceed with scleral fixation. Two partial thickness scleral flaps are made at 5 and 11 o'clock position. One straight needle of a double-arm 10-0 Prolene suture is passed into the anterior chamber through the opposite side port, and a 26 gauge needle is placed under the scleral flap at a distance of 2 mm from the limbus and inserted into the anterior chamber from below the haptic, and the straight needle is docked inside it as close to the optic haptic junction and taken out. The other straight needle is taken out from above the haptic to form a loop around the haptic. The other haptic was placed in the sulcus, and the same procedure was repeated on the other side to loop the haptic, and the knots were secured under the scleral flap. The ends were trimmed. Minimal vitreous disturbance was noted, so an entrovitrectomy was also performed. Scleral and conjunctival flaps were apposed with glue and anterior chamber was formed. On the 7th postoperative day, a well-formed anterior chamber with no IOL tilt was noted under the slit lamp. So the lessons learned: careful creation of Hoffman's pocket in myopic eyes due to the possibility of thin sclera. Slightly loosen up the iris hooks just before IOL implantation and during IOL manipulation. Use of capsular hooks are preferred. Always have a backup multi-piece IOL and a plan B while dealing with complicated cases. Have confidence and patience to execute the plan B. Thank you.
Thank you so much, Dr. Nito.
Dr. Manas, I loved your video.
Thank you.
But boy, you were in a so tight situation, and I think you managed very well. My question would be, did you consider the option of implanting the CTR right after the rhexis was made? That would maybe avoid the need to use the iris hooks.
Yeah. Actually, I like to prefer to back the support anterior posteriorly with the iris first, and then do the CTR. Probably that's the reason I started with placing the iris hook first and CTR at the, next. Sometimes, like if I've seen some cases where if you don't put the iris hooks, sometimes implanting the bag, CTR will be a little difficult because the bag will tend to move tangentially. And once you have supported the bag with two iris hooks or whatever iris hooks, it will hold the bag in that position anterior posteriorly, and implanting the CTR will be a little, comfortable.
Okay. Just one question: why did you use iris hooks and not capsular hooks? Because that might be one of the causes for that nick, you think?
Yeah, I know. That time the capsular hooks was not available with me. So routinely we are using the iris hooks in place of capsular hooks as well.
Dr. Manas, is a young patient with a absence of zonules in a particular segment. I presume that the rest of the zonules must be pretty strong because this was not something like a pseudo exfoliation. This was probably a congenital thing. Don't you think that you could have done this surgery without a need for a CT or anything, just like that, just with that coloboma in place? You could have done this, you think, in the hindsight?
The coloboma area was in the superior side, the superior nasal side. So I thought if I don't support the bag, probably because if I place the lens and then probably because of the gravity, I don't know, the lens may drag down or something like that. So I thought, okay, better, why not to support the bag and then proceed.
But also, as Dr. was telling, the easy thing and the right thing controversy always remains. Maybe one of the options which I would consider is to explant the IOL, allow the eye to be aphakic for some time till the fibrosis and the sturdiness of the capsule returns. And I would probably put a a multi-piece lens maybe in the sulcus on a later date, maybe after 6 to 8 weeks.
One difficult problem was that the CTR was already there in the bag. So I thought if I try to explant, I will, sometimes the CTR may dislodge and it can drop also. So I thought better not to explant the same lens.
But good thinking, well done.
Thanks.
Thank you, Dr. Manas. So we'll move on to the next video by Dr. Pankaj.
Hello everyone, my name is Dr. Pankaj Buragute. I am from Chandraprabha Eye Hospital. I have no financial interest in this video and I would like to dedicate this to my mentor Dr. Narayan Bodole. I am trying to inject some more HPMC from another side port, and then there I notice large anterior capsular rupture has occurred and which has extended till periphery at 10 o'clock and 5 o'clock. The similar nick was given in the superior part with the help of cystitome, and with microrhexis forceps I converted it into the rhexis. But by this time the pupil has become very small and my rhexis is also around 4.5 millimeter. So small rhexis, small pupil, extended rhexis, and along with the zonular weakness. And I am trying to chop the nucleus, and very comfortably I was able to chop it. I was performed carefully considering weak zonules and rhexis extension, and there was no rhexis extension till posterior capsule, and followed by that side port hydration and intracameral Vigamox injection is done, and case was successfully concluded. Thank you so much.
This is my Dr. Pankaj. My question is, how did you damage the anterior capsule? Hello?
Yes, sir. Sir, I think there are two possibilities. I might have touched with the side port while making the side port, or it was a case of a pseudo exfoliation material deposition. So maybe my direction of a visco cannula was exactly towards the deposition of material. That is more likely, I feel, and that sudden gush of a viscoelastic, because of that, capsule might have gave up.
No, my observation is it's not intermittent cataract. Usually you should go
Pseudo exfoliation, sir.
No, that's okay. It's not intermittent to lose the rexis. Here, what I observed is when you were entering, pushing the viscoelastic, I was not in an anatomical position. So what I believe is when you are doing side entry or even pushing viscoelastic, at least you wait till eye comes into rest in an anatomical position. It was away from the anatomical position, so probably you will lose the control and depth perception is lost. One. That is my observation. Second is, in spite of small rexis, in spite of loose zonules, that is pseudo exfoliation, and compromised rexis, what made you to continue with phaco? Because you had two choices.
Sir, I thought that if I chop the piece and take out the first piece, then there will be enough space in the bag. And then if bag is, then again, if I see that zonules are very weak, then I might have converted. But I feel that I can continue after emulsification of first piece. I feel that bag is enough stable to continue with the phaco emulsification.
No, you are lucky and your manipulations were very meticulous. You got away with this case because it's really difficult case with all the three problems together. Whenever we have two choices, whether to continue phaco emulsification or SICS, when you have a compromised rexis, we have to consider the grade of the nucleus, zonular status, corneal endothelial status, which machine you are using, which viscoelastic you have, whether you have a backup VR surgeon or not. Your previous encounter with a similar case is also important. So you will be more courageous to go ahead if you had a pleasant experience previously. And you should be ready to convert at any stage. Not that you have decided to do phaco and go on doing phaco. At any point of stage, you should be in a position to convert the case to SICS.
Yes, sir.
Perfect. Mohanta sir, would you like to comment?
Hello?
Hello, yeah, you're audible.
Yes, sir.
Comment on what? Which part?
On this case, if you want to comment anything on this case.
No, he managed it nicely.
Yeah, I think Dr. Pankaj is the only DNB student who has contributed to this, and we must, congratulate him for doing this excellent surgery.
Only the good factor of this case was that it was a soft nucleus. It were to be a hard nucleus, I would not have gone for a phaco with all these three compromises together.
Yes, sir.
Okay, so let's move on to the next video here.
Capsular bag distension syndrome has seen an increase in incidence due to the reduced diameter of capsular rexis. Near complete aspiration of OVD from the bag is a crucial step in minimizing this problem. IOL implantation under continuous irrigation prevents retention of OVD in the bag. In patients at high risk for capsular bag distension, like those with a smaller rexis or a sulcus fixated IOL with optic capture, or those with greater axial length, a peripheral anterior capsulotomy is created using a 26 gauge needle after IOL implantation. This is done under continuous irrigation. This creates a communication between the bag and the aqueous, reducing the chances of capsular distension syndrome. peripheral anterior capsulotomy will completely eliminate capsular distension syndrome.
Okay. So, Professor?
Thank you, Dr. Bhaskaran, for this describing this syndrome. My question, you are putting this as a preventive measure for this syndrome, isn't it?
Yes.
You know that this is a rare syndrome which can occur in about 0.7 to 1% of patients. So I really would, with the availability of these India glazer, I will not do it as a routine in these cases with a small capsular rexes, because you are making just a line. How would you make sure that it will do the job? So and it is, as we said, rare. So I will not really. Do you have study which showed the efficiency of this? I would recommend to follow up these cases. If your small capsular rex is small in the beginning, you can enlarge it by the end of the surgery. But to recommend it in every case of small capsular rexes, that might not work well, and that might jeopardize the zonules. And this is in general feeling.
Good evening, sir. Thank you for the.
Jayaprasad, can you start your video?
Yeah. Good evening, sir, and nice being here with all of you. Now, let me tell you that I've got a follow-up of 5 years now on all these eyes, and I believe that capsular bag distension syndrome, what we see as turbid, is a delayed capsular bag distension syndrome. All of them are actually cases of early capsular bag distension syndromes which went Now keep lifting up a small flap which will act as a valve, so that whenever if you have fluid inside the bag, it will definitely go out of the bag in the early capsular distension phase. Most of the time, I believe, including myself, we often do not diagnose this entity. We do not leave it because at the most the patient may have -1 diopter spherical surprise. So these are often missed in the early post-operative period. But over a long time, I have got patient who has come back at 25 years after surgery, whom I operated in 1995. At that time, it was a 3-piece lens with an angulation, but still there was most probably a lot of viscoelastic retain in the bag, which pushed that lens, the optic up, which came and sealed the anterior part and produced this capsular bag distension syndrome. So I feel when there is a risk, like I keep all my rexes at 5 mm and not 5.5, 5 mm to ensure that I have 3.
Yes, you know, in the theory of causation of early and late capsular distension syndrome, there's a difference. So and the treatment, we don't treat every case. Sometimes just observation if there's no symptoms, and if the vision is okay. So unless you have a published study which says it is very effective, because I see scratch only, and is it really needed or not? This is maybe left to get second opinion from the senior guys here.
Can you hear?
Dr. Deepak?
Can you hear?
Do you hear me?
Yeah, you're online now.
Do you hear me, Dr. Jayaprasad?
No. Are we just missing the point that why not remove the viscoelastic behind the IOL? I mean, it's a normal step in the phacoemulsification. I think doing that meticulously probably would avoid all this, and making a nick with the anterior and posterior capsule coming together. There's many a time they get closed because most of the capsule will adhere to each other, and this may not remain patent by the time that this can happen. I think probably little far-fetched. I think this should not take away the basic message that removing the viscoelastic from behind the eyeball probably is a very pertinent step.
Yeah.
Which may avoid requirements.
I think one of the practical use of this particular technique is, as he has mentioned in the video, is when you are doing a optic capture when the bag is intact. And sometimes even if you leave little bit of viscoelastic can lead to capsular distension. I think in that particular scenario, this looks like a good technique to avoid the early capsule. Like I think one of the technique, Dr. Deepak has one video, IOL trap technique in pseudo exfoliation, where he puts the 3-piece IOL in the sulcus and captures the optic in the bag. And sometimes it is difficult to remove the entire viscoelastic. So Deepak, yes.
Yeah. See, I have done an OCT-based study for more than 25 eyes of this IOL trap technique, where the haptics are in the sulcus and the optic is pushed back. This is for generalized zonular weakness for pseudo exfoliation. In this case, there is a back distension. It's not because of retained viscoelastic. I have removed the viscoelastic completely, but because there is a lot of space between the posterior capsule and the IOL, what I noticed is there is enough space for the epithelial cells to migrate. And all these cases have got an early onset of PCO compared to a regular in the bag lenses, a classical, because the PC is far away from this. By doing a opening in the peripheral anterior capsule, whether this is going to reduce the space and whether it is going to bring proximity towards the posterior capsule, that has to be studied by OCT, based. Then only I think, but it's a very lateral thinking. It's a very nice way of thinking. And capsular distension syndrome does not always happen because of leftover viscoelastic. The proliferation of the leftover epithelial cells, they produce a milky turbid fluid over a period of time, and that is what we collect behind the lens. Many times you see, many of the 5-6 years, you see a turbid fluid behind this thing. When you do an yak capsulotomy, it just liberates. It's not viscoelastic. It's the milky fluid which is generated by the proliferated epithelial fluid cells. And what I'm interested in is when you do an IOL trap technique like this, the space in between the lens and the posterior capsule is there. And that is the reason why the PCO happens earlier. But I am not sure whether by doing this neck, we are going to bring the optic much more closer to the process. But it's a different way of thinking.
I think
Congratulations.
very innovative. And I think one of the theories of capsular distension is not retention of too much of visco, but even little bit will increase the osmolarity of the fluid behind the IOL, and across the posterior capsule, the fluid gets imbibed, and that's why it's milky. I think commonly what we do is we do yak capsulotomy, which releases it out. But I think it's a very nice technique which needs to be studied further.
OCT would have helped you a lot. You should have done OCT for all these things. It will give you more value.
I have studied for 100 cases or now over the last 15 years. I'll come out with the results in the next year.
Professor, yes. Last comment.
Yes, I think Dr. Jabarasad, one of the things, you did a nice procedure, but the cost effectiveness, but one of the ways to prevent early CBS is hydro implantation of the intraocular lens. I think this is really a good procedure. And then I can, as I told you, we don't treat every case of CBS. When we need to do YAG laser, we can do it in the anterior capsule with dilated pupil, and we get a nice hole if we want. The established procedure is YAG laser posterior capsulotomy.
Okay, so let's move on to the last video here. Thank you so much, Dr. Jayaprasad. It was excellent. The next video is by Dr. Pratik.
I implanted the monofocal hydrophilic IOL in the anterior chamber. As you can see, the IOL has broken, maybe due to faulty loading or some cartridge issues. I tried pulling the IOL from the main wound, but it failed.
So here you go, Dr. Deepak. I think probably Dr. Pratik paid only half the money to the company. So they provided half the IOL.
I think we have Pratik. I think
yeah, am I audible?
Yeah, you're audible. I think
Okay.
Do you think would have prevented in some way, because we have all done this? You're not the first person to do this. We have all broken the lenses when you're doing this. Did you feel you could have avoided it in some way?
Actually, while I was implanting the IOL, I could feel the resistance in the cartridge. But previously, I was lucky enough to implant the IOL, so I thought that maybe I should go further. And that this was my mistake, so I should have avoided this.
Yeah,
and
I think this is the single most deadly temptation which we have. We know that when you're trying to push, we have got resistance, and we are sure that something is wrong. But that inside temptation is there, to just go, we'll try, and that is very deadly. And that is the reason for all the sins we create. The temptation is the sins, temptation to continue in spite of knowing that the resistance is there. So having
Deepak, live surgery, MM Joshi Hospital.
Yeah.
So I have one question for the judges. So can we remove this IOL, the broken IOL, in the anterior chamber by rolling the IOL, because it is a foldable IOL? So can we roll the IOL in the anterior chamber itself and then remove through the main wound?
See, I think there are multiple.
I think done the half job by cutting the IOL into half. So you can just pull it out.
No, sir, but it was not actually coming out because the size was quite big.
There is one very nice technique by Dr. Sri Ganesh. If you have seen his way of doing, what he does is that the inner lip he enlarges little bit for this kind of IOL, and then it becomes like a inverted funnel, and where you can pull the IOL out. Yes, Professor.
Yeah, I have just a tip for you, Patrick, because you said you hold the IOL from the weakest point, which is the haptic. So what I do, it is already broken. I would hold the IOL from the strong part, which is the optic, with serrated forceps, and it will come. But you hold it from the weakest point.
Okay. Right, sir.
Thank you. So here we come to the end. Deepak, so now the next part will be announcement of the winners. So here we
go ahead.
And
please go ahead.
thank you so much.
Thank you,
congratulations, Dr. Shashvati, for excellent educational video.
Thank you so much, sir. Thank you.
Thank you. Let's move on to the next winner. Heartiest congratulations, Dr. Gadre. I think it was one of the toughest complications that we saw during this.
Thank you very much.
Dr. Manas.
Thank you, sir. Thank you.
I
Thanks
think
a lot.
fantastic way you managed the case.
Thank you. Thanks a lot.
Dr. Jaya Prasad. I think it was an innovative idea that we had not seen before, and definitely there is a way we can evaluate it. Thank you so much. Congratulations.
Thank you very much.
Congratulations, both of them are young surgeons and they decided to present, and that was our aim actually to promote young surgeons so that they can do more video recordings and contribute to the learning for all the surgeons. So congratulations all of you. All the winners will be getting some gift hampers, I would say instruments, from our co-sponsor Mr. Ajay Mahajan of Cardiocare, and the two young surgeons will be getting a gift 23 gauge microcapsular axis forceps for their contribution. So congratulations all of you, and okay, these are just results, but I think we loved all your videos and so much to learn from all the videos. And Dr. Deepak, for the vote of thanks, please.
Deepak, all of them have declared no financial interest, so don't give any prizes.
Sure. And I would like to also acknowledge Novartis for giving us an educational grant through which we'll be giving prizes in the form of instruments so that they will help them in doing some great surgeries in future.
First of all, I'd like to thank all the delegates who have contributed with their videos and are brave enough to show their complications. I think the first thank you goes to you all guys. You are all winners. Unfortunately, we can't give prizes to all of you. So people who couldn't make it, no heartbreaks. You are always welcome to participate in the next competition and win over it. Next, my heartfelt gratitude to all the judges who have spared their time in evaluating these cases, these videos for us, given their time for evaluation and also attending this webinar, and also share their valuable experience, which is we are very grateful to you. And from NITO, Professor Al-Khatani, Dr. H.M. Ravindranath, Dr. Pradeep Mohanta, and last but not the least, for our chief guest, Dr. Krishna Prasad, for sparing his time and taking time to inaugurate our website and also wishing us well. And lastly, thank you to all the attendees who have stayed up till so late to hear this thing, and also to our sponsors for providing us the monetary support to conduct this competition. So thank you once and all, and see you in some time soon.
Yeah, before we finish, I would like to just have a few words from our esteemed judges and chief guests just to give some motivation for all our young surgeons over here who are attending. Dr. Nito, please.
Well, I surely would like to take the opportunity to encourage all of you to not only record your surgeries, but to post them, to upload them on YouTube or other place, because I think the feedback we get when we do that is wonderful. And so I strongly encourage everyone to do it.
Professor Al-Kathani.
Professor Al-Kathani.
Thank you very much, Dr. Sourabh and Dr. Deepak for this meeting. And I would like to tell also, I'd like to thank the colleagues with me attending. I would like to tell the surgeons, the young surgeons, that life is surgical life is not just at one step. You have to continuously upgrade yourself, and you never think that you are the best surgeon. Don't hesitate to learn from the young surgeons. Every time we learn, I learned from you today a lot. So, and thanks to all of you.
Thank you, sir. Dr. Pradeep, sir?
Complications are going to happen if we do surgery. And always I remember that we have to learn to manage complications. I always remember a quote of Mr. Jim Rohn that wish not it were easier, wish you were better. Don't wish for less problems, wish for more skills. Don't wish for less challenges, wish for more wisdom. We have to have that acumen to manage complications. Complications are going to happen all the time throughout our surgical career. So we have to be better every day. We have to master skills to manage those complications.
Thank you, sir. Dr. Ravindranath, sir.
Actually, youngsters are more lucky and more skilled and more fortunate. More skilled because they are young, more lucky because they have opportunity to see all these videos, and technology has given a lot of support to them. We usually learn from our mistakes, but they can learn from others' mistakes by attending a lot of YouTube channels. I have learned a lot from you guys actually from these complications, and accept the complication. First, you try to see the problem in you first instead of blaming on others. That is the first thing you should do. So take blame on you and try to improve next. And you record your all surgeries, and if there is any complication, rewind it same day and write down how could you avoid that complication. And thank you both you youngsters, Deepak and Sourabh, for this wonderful opportunity for youngsters. Sure, it will be a very good platform to learn a mistake, do our mistakes. And
very happy birthday to you, sir. Today is his birthday. Still see his dedication. He's staying, for our webinar. Thanks a lot. And
the problem was, I'm COVID positive. This is my 10th day. I didn't know whether I would participate because 3 days back I had some small lung lesions, and I was not sure whether I'll participate. But your enthusiasm made me to cure my disease, and
you are always positive. You are always positive, sir. You will stay positive.
Thank you.
KP.
Dr. KP, the finishing touch.
I think it's a nostalgic feeling because every time at this part of the year, we have a program by all our FECO friends called FECO Potboiler. Yeah. It's a very robust meeting with a lot of vibrancy, and the two bright minds of this particular meet that we have is Dr. Deepak and Dr. Sourabh. They're always taking the lead role in these programs. So I thought I was missing it this year because of this pandemic situation, but you have made it up for the deficiency. So very nice. It's a great opportunity to be a part of this. I learned a lot, and I hope this fecotraining.org.in will fill the gap in disseminating this particular information about everything about that under one roof, under one website. You can get everything. I think this will be the all for every need of a FECO, enthusiast. This should be the final stop. I hope that this will grow from strength to strength and will become a hallmark. It becomes a real, a one-stop shop for all our FECO needs. And congratulations for starting this great venture. And we hope, and I wish, and I bless all of you for taking it to a greater height. Congratulations and all the best.
Thank you. Thank you so much.
Thank you so much. And all those who presented the complication, I would like to say, I have done more severe complication than this. So don't get disheartened by, comments of the judges. I can show my complication next time.
I told no, if you do a complication which is not mentioned in the book, then you bother.
Yes. Okay. So we'll now mention all these in books now.
If you see a complication which is not mentioned, report it.
Report. Thank you so much.
Thank you. Thanks a lot.
We are really honored by your presence. Thank you all the participants and all the attendees. Thank you.
Thank you.
Signing off.
Thank you so much. Thank you.
Thank you.